itself to a system that you believe is foolproof. How should Kenyans start actually questioning who is on the other end of the table, or how can you be sure that the person who is working on you is actually licensed to do so?
Well, I think the responsibility will go to the regulator.
Yourself?
The regulator, myself, for doctors, the nursing council for nurses, clinical officers for clinical officers council, the laboratory board for lab boards, the pharmacy and poisons board for for pharmacists, and nutrition. And then because in an hospital setup there are various healthcare professionals, and every healthcare giver is regulated by a certain profession. Now, it is the responsibility of the medical superintendent and the county chief of health to ensure that the people working within their own units do meet the required, the set requirements. If there is need to cross-check with us, there is that window is open. However, as a board, I must say that Kenyans need not to panic. The number of doctors that are registered now goes to about 10,000. Active doctors is 6,500 that are regularly licensed by the board. What is going to happen is that by 31st December, the list that is on our website of doctors will go down, and we shall put another list of the doctors that will be required to work as doctors in the year 2017 up to December. Now, if a Kenyan doubts that this person is not a doctor, simple procedure, code number 20547, send. The message will come back with the details of that particular practitioner.
Say that number again.
20547. That is our short code, which we have put connected to our register.
So is it up now?
It's up now. It's up now. Should be up and running. And that is the short code message that we have given to patients. For those that are ICT compliant, who have phones that have details, we have set up an application. We should be up and running by the end of the year. This application will be able to key in hospitals that are near you and the doctors that are near you and their qualifications, so that if there is an accident on Mombasa Road and you are near Chumfi or you are near Mariakani, you key in, you get the nearest health facility and the nearest health giver and their qualifications.
I want to take you back to the short code. So once you send a blank message to that number,
with the name of the person,
okay.
Yes, so that it now gives you the details, the qualifications, to send back details, and that message is helping, because hospitals do that when they get people apply for jobs, and the patients can do that. Now, what we have discussed with and we are in discussion with the Cabinet Secretary for Health, and we want this to go to the Council of Governors, is that we would like all health workers to have professional badges, identification badges, because even if you work in a certain health unit, everybody in a white coat is a doctor, and we have cases where even laboratory technologists, nurses, clinical officers, or alarm
people in chemists and pharmacists.
Yes, so we like we are now moving that. The Cabinet Secretary is in discussion with the Council of Governors. We want this to be accelerated so that every institution you get that. For us as a board, what we want to do is that we want to go a step further and make not just a badge for identification. We want to have it with barcode, with all the details, so that if you put it the barcode reader, it can give you the details, so that forgery is eliminated, and then practitioners can be identified easily.
And so when do you expect the online platform that you talked about will be working, other than the short code?
The short code is working. The online process is going to work by the time we go for Christmas. We can give it by 20th of December. It should be up and running.
And the rest, the badges, you're in discussion.
Yes, so that the government can give a directive, and then you know if there is buy-in from the counties and everybody supervises their own institutions, that becomes easier. We will not have any challenges. I think that's basically what to do. About the issue you asked about our following up on inspections, regular inspections. Yes, it's true. We carry out three types of inspections. One, we inspect medical schools and dental schools. Two, we inspect internship training centers like the Kindu Bay one. And 3, we carry out joint inspections with other regulatory bodies to health facilities and clinics across the country. So these kind of inspections are geared towards ensuring that at least 1,000+ facilities are inspected in a calendar year. And that we have done.
I wanted to find out from Yumbia whether you are satisfied with the standards of training in the universities, because universities these days have become commercial. They are more interested in bottom line. So anybody can go and study to be a doctor. And are you sure that the doctors you are getting from our universities are not doctors? They are quacks.
That's a very good question. Kenya, in this region of East Africa, we lead in regulation. 1, for medical schools, we developed guidelines, our national guidelines for inspection and accreditation of medical schools. We accelerated that document to the East African community. So among the 5 partner states of East African community, we have 35 medical and dental schools. We have developed a unified document approved by the Ministers for Health in the East African community. We have inspected jointly all the medical and dental schools in the East African community. Kenya, only 1 university was given 6 months warning. In Uganda, 1 university was suspended. In Tanzania, 4 universities were suspended from admission. We have re-inspected the one in Uganda. It was returned to admit. Tanzania has 4 universities which are pending, including the University of Zanzibar. And these ones we have to re-inspect again in January.
In public interest, which university in Kenya was given the warning?
Uzima University.
You didn't mention Uzima. You didn't mention it.
I'm saying, you asked me in public interest. It was given a warning, and we are monitoring.
Uzima is a private university.
It's a mission university.
And what was it
they are
found?
They are in their third year. Of course, the issues that we are looking, one was staffing and facilities, and we are concerned about the clinical training for doctors, because you can not give lectures and you don't undertake clinical training for your students and expect them to see patients. That they were given, and we are set to visit them by January to give them, to assess what they have attained.
Since we devolved health, many hospitals are now called training, referral and training. What has changed?
Very good. I think that's a very good question, Mutegi. We noted that problem. In fact, we have a document now which is waiting discussion with the Cabinet Secretary and the Council of Governors, so that now we have developed new categorization for all the institutions, beginning from a standalone clinic to a level 3 or level 4 hospital, so that you do not just say this was a former health center, it is a sub-county hospital. This was a dispensary, it is now level this. So we have now developed with the relevant stakeholders a document which is awaiting approval by the Cabinet Secretary for Health, upon which the Council of Governors will also look at it and approve, and then we gazette. I think we will expect a new categorization to be gazetted by the government in consultation with the board by let's say latest January.
As of now, who is determining which is level 4 or which is level 5? Or they just declare, since we have devolved,
as a board we want to come in, because we realize that counties are making declarations and facilities that otherwise do not meet the criteria of a certain level are being given that level. And as a board we have developed, we call them together, we sat, we have a draft. The document is in a draft form which is almost complete.
So when you hear level 4, it's not necessarily level 4, it's just a name.
We will now have them categorized afresh depending on the new guidelines, because we do not just want to get names for the sake of them.
So you think counties previously have been doing this without consultation?
No, there is the existing regulation within the policy within the Ministry of Health, and the Council of Governors have got their own policy document, and as a board we have come in and said, bring your document. The Ministry brought theirs, the Council of Governors brought their document, we brought ours, and then we have now harmonized. I think the positive thing is that he's asked a question which I have an answer, because I have a draft. After this show, if you want to share with the draft with me, I can still give it to you as a stakeholder. You can give me your input, and probably we'll put it in.
Mr. Yumbia, for a hotel to be called 5-star, it must be inspected and facilities found, and the food there and whatever facility the categorizers, the people who are grading have a standard. Now for you, I am a governor, and I know I want to please those fellows, so I say this is a county hospital, is refer for just a name.
No, I don't want to say that they are giving this to please their residents. I said their grading system, the one for the Ministry of Health, the one for the medical board, has been harmonized. We have a new grading system which should be up and running within a month. Is that the shortest time I've given you? So within a month we shall get the correct document, and it shall be up and running. And if you need to look at it, because you may have your input, Mutegi,
it has been going on for years since the revolution.
Prior to that.
So why are you saying we will do instead of saying we did?
No, I won't say we did, which we didn't do, Mutegi. I think it's always good to accept where there is a challenge, and always to give a solution where you've gotten a solution.
When Ayumbia, the element of professionalism, even with your registered members, today there is hue and cry from among culpable patients that the bottom line is the issue to most doctors. Money first, service after. What can you say about that?
I think I will say that the public have a right to complain. We developed the first National Patients' Rights Charter, which is here. This charter has two sides. One, it has patient rights. It also has patient's obligations. Now, in the patient side, right side, we look at what is it that the patients expect from practitioners. And we have said time and again that regardless of the status of the patient, doctors have taken the Hippocratic oath, and the consideration of the patient should be above every other consideration. And therefore, if a practitioner is not doing what is expected of them, they are doing wrong. We have handled a number of cases. The cases that we have handled so far, about 940, 960. And about 100 cases are related to attitude, where you go to an institution, and by the way, some of them don't touch on doctors, they touch on nurses, they touch on clinical officers, they even touch on finance. And a patient is in pain, and what they expect is, first of all, sympathy, empathy, and they need to be communicated to properly. So I think that is an issue that is individualistic, and we will not give a blanket condemnation to doctors and say that they are not doing correct. But those that have not done what is expected of them, we have taken action against them.
What kind of action have you taken?
Now, the penalties are stipulated in the Medical Practitioners Dentist Board Code of Professional Conduct and Discipline, and in our regulation for PIC and PCC and Full Board Tribunal. The penalties range from admonition to suspension, to order for training, or deregistration, cancellation of a license, and so on. So they depend on the level at which the offense is weighed at. But I must say that with the Kenya Constitution 2010, Kenyans have become very open society, and they know their rights, and they have a right to complain where they feel things are not going right. And the professionals have also a responsibility to ensure that they offer services that are beyond reproach. And therefore, the patients require communication, they require respect, and some of the issues they raise, they say, if the doctor told me that, I will not be at the board. So we also appeal to them to ensure that they communicate. If not doctors alone, every healthcare worker, be they nurses, clinical officers, laboratory technologists. Let
me return you to the question of quacks. In your time as CEO, would you say there's been a proliferation of such cases, a reduction? What is your own estimation?
My considered opinion is that the level of quacks in this country has completely gone down. And I will give you two examples. One, we used to go as a board, medical board alone. And you go to a clinic, the person says, I'm a nurse. We did not have access to that facility because CAP 253 does not allow the medical board to inspect a nurse's clinic. Even a pharmacist, I have no mandate of a pharmacist in this country because the Pharmacy and Poisons Board Act does regulate. Now we carry out joint inspections every year and we see about 1,000 facilities. The other bit is that there are cases, I can take you to Kericho, where we arrested a quack. This quack tried to beat himself so that we can be the one accused of beating. We had the media people with us. That fellow was taken to court, charged. Later on, when we went there, he's selling spirits. He moved out of the business. Another case in Mwingi. These are cases I can take you. A lady called the flying squad, so said we are thugs.
There really isn't any data to prove that.
The data is there because the number of facilities that were closed recently, I'll give you the counties that we have. My dear, I work with the data. Out of the 279,
yes.
Out of the 200, thank you for correcting me.
You're welcome.
Yeah, 279 cases that we inspected between the 7th and 11th of this month in Trans Nzoia, was in Gishu, Elgeyo Marakwet, Nandi and Baringo County. Only that 8 facilities were closed and only 7 quacks were arrested.
And when
so I'm saying this was done between the week of 7th to 11th November this year, and we inspected 279. So out of this, only 7 quacks have been arrested. So you can see there are times you'd get the number of facilities closed would be half of that, and you get the number of quacks that are arrested would not be less than 36 in a particular county. But these are 1, 2, 3, 4, 5 counties, and out of 5 counties, you find there are counties where we didn't arrest a single quack. Therefore, the level has really improved.
Do you think the cost of training medical practitioners encourages these cases of quacks? Is cost related to medicine a challenge in any way in getting the best practitioners?
Not at all. Not at all. One, for you to train as a doctor, you must score high grades, and you have other professions that you can undertake if you so wish. A case of a quack is a calculated move. It is like Mutegi said, even in the police, in music, quacks plan how to execute their goals depending on their aspirations. And as I said, these are people who must have interacted with health professionals at a certain level, and they got that inspiration, and probably they failed in internship, they failed in their first year, they failed in their second year, and they have that inspiration.
When it comes to low incomes, I beg your pardon, Mr. Gi, low income communities, you would find that people go to clinics where it's quite doubtful that they will go to the extent of, even checking out the short code that you've given us, simply because there is a desperate need for services in overpopulated areas, in low-income areas. Does the cost of healthcare also in some way contribute exactly to this sort of situation?
Yeah, I'm a Kenyan, and I'll admit, I'll say yes. In fact, most of the quacks now have moved to the informal settlement areas. If you get Mombasa Road and you start from Machakos up to Mombasa, you'll get very few quacks within the highway. But if you divert and go to the villages, and you get to a place where in the very ferry, and you go to the informal settlement area, you find that's where people take advantage of the vulnerable. Towards this end, I think we have been in discussion with the government, and that's why the government is looking at setting up mobile clinics in this informal settlement area, so that the less fortunate can be addressed, can be attended to. And I also want to thank the county governments, because with the devolution of health, that is one area where they're also struggling to establish facilities. And I've gone from one corner of this country to the other. They are trying to establish facilities in every area. However, they do not seem to have enough health workers to address that. So what we are saying is that equipment and health workers, facilities and health workers, so that the patient, what the patient needs is the facility, the nurse, the doctor, the clinical officer, and the drugs and the diagnostic equipment, so that can be done. But you see, Rome was not built on one day. When you look at it from this perspective, you are a taxpayer, I'm a taxpayer. So we are looking at, given time, I'm sure that Kenya will be somewhere. And given time, healthcare provision in this country will continue to improve, and these so-called quacks will have no space.
To what extent does the issue of payment, salaries, remuneration contribute to the upsurge in the number of quacks?
I do not come into negotiations for welfare for doctors. I don't. My board's mandate does not move to the union. That's a role for the union. So I don't want to divulge into matters. Let's confine ourselves to the mandate of regulation. But I don't think wage would now be an issue in terms of a quack. A quack is somebody who is looking for quick money, somebody who doesn't have...
No, what I mean is, because of the gap, a doctor looks for greener pastures where they are paid much better, and so they leave a vulnerable population that resorts to being attended to by quacks. That's what I mean.
No. You see, the Kenyan government has done it in a way that is acceptable to all the cadres, because you see a nursing home, a medical center, a dispensary, a health center. You do not need a doctor to go to a dispensary. So those small units are taken care of by clinical officers, and Kenya has got quite a number of clinical officers who are capable of doing preventive and curative at the periphery, as opposed to... Actually, a doctor should not work in a place where there is no theater.
Let me ask you about your period as a CEO. Have you ever deregistered a qualified doctor who deteriorated from a trained doctor but also became so unprofessional to the extent that he was found incapable of treating people and was deregistered?
Mutegi, I was here some time back, and I said that there is a doctor we deregistered.
Just one?
One doctor we deregistered about 4 years ago. 4 years ago, because he's mismanaged a patient in Mwingi, and that matter was found to be serious, and according to our regulation, he was deregistered. Quite a number of doctors have been ordered to go for retraining. We have ordered quite a number of doctors to go under training. When we order you to go for training, you go under attachment under somebody. That person must write a letter to clear you, and you are supposed to rotate in certain areas and do certain procedures under supervision, and they have complied. Some of them are senior doctors, and they have done it. Others are junior doctors, they have done it. Because when you find a doctor who is a consultant and does not meet the requirements set by the board, then the board orders such people to go for training and go CPD programs, and the doctors comply. It's CPD? Only that CPD is continuous professional development. You know, medicine keeps on evolving, so we do not want doctors to stay in the old age and not get updated skills. Therefore, doctors do that, but it's that we don't do it in the media. It is done professionally under the cover, and they do it. And they
Yumbia, those doctors who do private clinic, you'll see Dr. V.D. Patel somewhere in River Road. He has been practicing that clinic since 1924, and he is practicing even today. Who will make sure that that doctor is trained? In fact, you go and they prescribe medicine which was not manufactured in 1913.
Mutegi, no.
So that's actually banned.
No.
Yes,
Mutegi, that's the only area I differ with you, because for me to renew doctor's license every year, and that's why I say the register will come down on that 1st December. Of course, I may not bring it down on that 1st December. I bring it down on the 10th of January, then give them up to 15th to put in the new register. Yeah. Every doctor must undergo 50 points CPD training. Every doctor. And of course, not all doctors go 50. Some even go 60, others go 45. But when you will see a doctor has undergone the training program, which is almost average, we can still tell them now, we give you up to January, you comply before you get your license. And that is what we are doing. We are living in international standards. I mean, in an era where the world is a global village, and the medical board is a member of the Association of Medical Councils of Africa. Actually, Professor Magoa chairs the Association for the Boards of Africa, and I chair the finance committee of that board. January this year, I had the privilege of being appointed a member of the management committee for the International Medical Regulatory Authorities. This is an organization that brings about 100 boards together, and we sit every year and we share information. One of the things that we share is those doctors that have been registered, those doctors that are a danger to the society, and we share this information, and we make sure that we set standards that are cutting across. For example, the issue of CPD is an acceptable international practice where we have agreed in Africa that doctors need to get these points. The issue of information exchange is a practice we are doing with our counterparts all over the world, so that doctors, if this was a doctor, if this guy was a doctor, then I would have flagged his name on our website. But since he's not a doctor, I will not flag his name.
We appreciate the fact that you work in the villages today, that nurse, and you confessed it earlier, that pharmacist, that clinical officer are all referred to as doctors. What is your regulatory authority doing to ensure that there is that patient confidence in these people after this incident?
Yes, what I said is where I said I'm now waiting for the decision of the cabinet secretary, where we are saying professionals, health professionals must have badges, identification badges, so that you say laboratory technologist, nurse, because even that nurse assistant, the nursing council doesn't like the title nurse aide. That nurse assistant, you put your nurse assistant, but you see they will be called doctor, because my mother in the village, anybody in a white coat in a certain health facility is a doctor. But you see, when my mother goes with my brother, and it's written here nurse, it's written here doctor, is here written ops and gyne consultant, they will know this is the person who consulted, and this is the name of the person, so that this can build confidence to them.
All right, we're taking a short break. And Cheche, we're back with your questions. Send them in. We'll be back after this.